Okay, so good afternoon, one and all. Um, I welcome you on behalf of National Neonatology Forum on this yet another academic session on neonatal meningitis. So today's topic is on neonatal meningitis, and we have eminent speaker with us, Dr. Rajendra Prasad Ani, who's assistant professor neonatology at Kasturba Medical College, Manipal, Udupi, Karnataka, and he will speak on the topic of diagnosis and management of neonatal meningitis. This will be followed by neuroimaging in neonatal meningitis topic, which will be given by Dr. Manisha Jana. She is a professor in the Department of Radio Diagnosis and Interventional Radiology at All India Institute of Medical Sciences, New Delhi. So we have two very eminent speakers on this very important topic on neonatal meningitis. And at the end, we can have question and answers and a lot of discussion on this. So this topic is always it is a very common problem that we see in neonatology day in and day out, and we often wonder how we uh, move forwards. So this is a very important topic, and today we also have with us Professor Dr. N.B. Mathur sir, who is the next director, professor and head neonatology from Mansi, New Delhi. So welcome, sir. So he is also with us for the further discussions on the topic. So I'll straight away start with Dr. Rajendra Prasad Ane from Manipal. Sir, over to you for the first topic.
Yeah, I would just like to mention that Dr. Rajendra Prasad is a true researcher who has done a lot of research on neonatal meningitis. So he's one of the students or the doctors who have done meta-analysis along with one of the pioneers of neonatal meningitis in India, Dr. Saurabh Datta. So we expect a wonderful, very academic webinar from Dr. Rajendra Prasad and from Kasturba Gandhi Medical College. Over to you, sir.
Uh, Thanks for the kind introduction, ma'am and sir. At the outset, I want to thank NNF Delhi for considering me and Saurabh sir for suggesting my name. And as sir has rightly pointed out, Amit sir, Saurabh sir has done a lot of work. I happen to be his co-worker in few of the studies. So I will start with the presentation. So the topic for the discussion today is diagnosis and management of neonatal meningitis. So I will not discuss any background of the neonatal meningitis. I will directly go into these two topics because this itself will take a good amount of time. So while managing neonatal meningitis, and especially when it comes to diagnosis, we face with several questions in our day-to-day practice. So I will address each of these questions in my coming slides. The objectives of my diagnosis section include when to suspect meningitis, when to do a CSF examination, and what all tests are required in a CSF, and how to interpret a traumatic tab where there is no traumatic puncture, and what will be the impact of delayed processing, and how to interpret the traumatic lumbar tab, and how to interpret the CSF done after antibiotic therapy. We don't have answers for each and everything. Some questions are still not fully answered as per the existing literature, but we will discuss them in detail. So when do we suspect meningitis? This is a common question faced by all the neonatologists and pediatricians who look after the newborn. So one important point here is the clinical presentation of neonatal meningitis is indistinguishable from that of neonatal sepsis without meningitis. In other words, clinically, it is not possible to differentiate whether a septic neonate has meningitis or not. So that is where the challenge lies. So the clinical manifestations are not obvious. Sometimes there are no clinical manifestations, and it is not possible to distinguish from sepsis just by clinical examination. The most commonly reported clinical signs, however, they include temperature instability, most commonly hypothermia. There can be irritability or lethargy, poor feeling, vomiting, respiratory distress, and apnea. And as you all know, all these clinical features are also common here. So we need to understand this. So there comes the importance of doing a CSF examination. So when to do CSF examination? So we have two different settings. One is the late onset sepsis and the other one is early onset sepsis. So in is when it comes to late onset sepsis, ideally we have to do CSF examination in each and every neonate when we are suspecting late onset sepsis. That is any baby who becomes sick after 72 hours of life, and we are considering LOS as an important differential diagnosis, and we are starting antibiotics. That means that child, that neonate is a candidate for CSF examination. So screen positive, blood culture positive, all these actually come in this subcategory level. So if you do CSF for every baby with suspect LOS, that is the later two also included. But when it comes to early onset sepsis, there is some confusion here. So in early onset sepsis, we need not do for each and every baby, is what many people say. But I want to clarify on this aspect in the coming slides. So in the early onset sepsis, it is if the clinical course of the neonate is more like a early onset sepsis, then we have to do a CSF. If the blood culture is positive, then obviously we have to do a CSF. So practically, most neonates who are started on antibiotics with a suspicion of infection are also candidates for CSF examination. So are there any subset of babies we can skip CSF examination? So when it comes to late onset sepsis, it is proven or highly likelihood of a viral infection. Both there is a bronchiolitis, there is a viral infection outbreak in the family, or the bronchiolitis outbreak going on, and the baby develops symptoms which are predominantly respiratory. We are very it's very likely that the baby is infected with RSV or something. That is one scenario where we can avoid it late onset sepsis. When it comes to the setting of early onset sepsis, so babies with risk factors for early onset sepsis, but the clinical course is not like sepsis. The blood culture is negative, and you do have an alternative explanation for the symptoms. Suppose the baby is having a respiratory illness, and you know it is an RDS. The clinical course is very much like RDS, is the response to surfactant, they will improve. Then those babies are not candidates for CSF examination. And babies with predominantly respiratory presentation, they have very low risk of having a sepsis and meningitis. They are also not candidates. I will elaborate this further. So the background we should know why I came to these conclusions. First, we should know what is the burden of early onset sepsis. So if it is a proven early onset sepsis, I mean blood culture positive early onset sepsis, in those subset of neonates, almost 1/3 have meningitis. So it's a very high number. And if it is a group B streptococcus, around 15% have meningitis. In symptomatic neonates born to mothers with risk factors for sepsis, the incidence of meningitis varies from 0 to 1.5%. In infants with predominantly respiratory symptoms, again amongst those born to mothers with risk factors, around 0.3% have meningitis. And asymptomatic infants with, of course, born to mothers with risk factors, none of them were found to have meningitis. So this is based on data from multiple studies. I suggest everyone to read this beautiful article from Neo Reviews, written by Greenberg et al. He is a pioneer in neonatal meningitis. They have nicely summarized all the studies. So we all know the classical UNS risk factors. So how to decide? So neonates with risk factors for early onset sepsis, we should see first whether they are symptomatic or asymptomatic. If they are asymptomatic, there is no indication for CSF because I have shown you the data. In such subcategory of neonates, the risk of meningitis is zero actually. We don't have any risk of meningitis. If the babies are symptomatic and the symptoms are predominantly respiratory, and you can attribute to one of the illnesses like maybe TTND, maybe RDS, maybe MAS, then they are not candidates for CSF. You can skip the CSF. But if they have predominantly non-respiratory symptoms, or symptoms are more like a sepsis, like they develop shock, they develop some multi-system involvement like feeding intolerance and hemodynamic instability, merima, metabolic acidosis, which are not explained otherwise. And the clinical course is very much like an early onset sepsis. Then these are candidates for CSF examination. And in any case, if any baby is blood culture positive, we should do a CSF examination. So what I want to tell you, in the setting of UNF, we should not restrict doing CSF only to those who are blood culture positive. We should also do CSF to the babies who are culture negative, but the clinical course is very much behaving like so. So this is what I want everybody to take home. Then when it comes to late onset sepsis, we all know in late onset sepsis, the incidence of meningitis is much higher than early onset sepsis. So overall, around 1 to 3% of all NICU admissions, they have meningitis. And among babies evaluated for late onset sepsis, the data is very across studies, 5 to 25% they have meningitis. So it is very high incidence of meningitis. And incidence increases with postnatal age. This is slightly paradoxical. The younger infants have lesser incidence, and at the age they have high incidence of meningitis in the neonatal group. So among neonates with proven GBS, I told early onset GBS the risk was around 15%. In proven late onset, it is quite high, 55%. And this is very important. Of the babies who have meningitis, around 1/3 they have negative blood culture. So why this is important? Some units they practice like we will do CSF only if the blood culture is positive. If you have that strategy, then you are likely to miss diagnosis of meningitis in about 30% of the cases, which is a huge number. So we have to be careful while dealing with babies who are having suspected of having late onset sepsis. So the same question, Saurabh Thakur et al. Have done a study which was recently published in American Journal of Dermatology. So is there any cohort of low risk babies with LOS where CSF can be avoided? They tried to explore this and they found the final answer to be no. I will just explain. So they studied around 300 lumbar punctures and 121 had possible or definite meningitis. So around 179 did not have meningitis. And they found that babies who didn't have apnea, who didn't have neutrophilia, and who had normal CRP, on multivariate regression, these three factors were found to be associated with lowest risk of meningitis. And they have identified a subset of neonates who had all these three features. That they never had apnea, they had never had neutrophilia, and their CRP was normal. So around 118 neonates had all these three features. But surprisingly and shockingly, around 1/3 of these neonates ended up having meningitis. So even the lowest of the lowest risk cohort of LOS, we cannot skip CSF. CSF has to be done in each and every baby where we are suspecting late onset sepsis. So when should we do the CSF? Ideally, it has to be before the first dose of antibiotic, but it is not prudent to delay the dose of antibiotic in a sick child also. So it should be as soon as possible. Like given antibiotics, maybe in the next couple of hours, we should be able to do the CSF without unnecessary delay. But if the contraindications are there, then if the bleeding neonate or the local site infection or the disease so compromised that you cannot do the CSF, you can defer the CSF for some time. But as soon as the baby improves or the contraindication subside, we should go ahead with the CSF examination. Then I will go with the details of the procedure. Actually, several studies have been recently conducted to increase the success rate of doing CSF. So what they have found is if you make the baby, especially a term baby, in sitting position, the success rates are very, very high because the intervertebral spaces are much wider, and this increases the success rates dramatically compared to the standard procedure we all use, which is the lateral decubitus position. However, this position cannot be used in preterm babies and also the sick babies. And if you come to the comfort, baby's comfort, like which position is associated with the lowest pain to the baby and the ease of holding, it is shown to be the prone position. But prone position has challenges in term babies. In preterm babies, some people are using prone position. But when it comes to the ease of performing a lumbar puncture and the safety to the neonate, like a intubated baby, or the performer is not that much experienced, then it is the lateral decubitus position, which most units, I'm sure, are using as a default option for the CSF. But we all should be aware that it is not the only position. People are using sitting position, especially for term babies, and prone position for preterm babies. And we all know the spinal cord is low lying in the newborn, it may reach up to L3. So ideally, it has to be between the fourth and fifth lumbar vertebrae, and at maximum, you can go one space. So fourth or fifth lumbar intervertebral space, we should do the CSF examination. And the needle we use smaller needle. It is preferable to use smaller needle, not a needle which fits into the intravascular space. Smaller needles have lower traumatic tag rates. So what all samples we should send when we do a CSF? So the first and foremost sample has to be CSF culture, because CSF culture is the gold standard akin to the blood culture we use for sepsis. So if you have only limited sample, only few drops have come, the first sample or the only sample is conclusive has to be CSF culture. The same applies to the traumatic tap. If there is a traumatic tap, first thing should be CSF culture. And CSF gram stain is also important. PCR, polymerase chain reaction, if it is available, that will help in diagnosis. Then we all know we send CSF cytology, including WBC, neutrophil count, protein, and glucose. So all these can be sent from the CSF. So how do we interpret? So there is a problem here. Still, we don't know what is the exact diagnostic cutoff. We only know this much: as the human being increases, the age increases, the number of cells may decrease. So smaller the baby or smaller the infant, smaller the neonate, the higher will be the number of WBC, the higher will be the protein concentration. Glucose doesn't change much, but when it comes, what is the exact cutoff which has the optimal diagnostic accuracy, we don't have an answer till now. So this is one meta-analysis where they have seen the normative value. So this is done on babies without meningitis, normal babies. And all these studies are done way back, a few decades back, because there are many ethical reasons you can't do for normal babies. So the 95th centile they found for WBC is around 10 to 12, and for protein is 210 per 3 term and 110 per term, and glucose is around 32. There is a 5th centile for glucose. So some people have adopted these as the diagnostic cutoff. So we did a meta-analysis, myself along with the professor, where we assess the diagnostic accuracy. So there are many numbers, but I will tell you to just focus on these three numbers which I have rounded. When it comes to CSF WBC count, the sensitivity of WBC count is around 90% and specificity is 87%. These are quite good numbers. That means it has a very good diagnostic accuracy. You can also see the area under south 0.89, which is fair, quite good. When it comes to protein, the sensitivity is around 92% and it is specificity of around 89%. Glucose has poor sensitivity, so we are likely to miss the diagnosis if you take glucose as the most important parameter. However, the main problem we face is the diagnostic cutoff used are variable across studies. Okay, so still we don't know what is the optimal cutoff, but we know that CSF WBC performs better, protein also performs better. Glucose is not that an ideal test, especially if you are using as a screening test. So among the studies which were used in my meta-analysis, the cutoff varied. CSF WBC was not the same cutoff. Some people have used 10, some 20, some 25, some 25. Similarly, the CSF protein cutoff varies, glucose cutoff varies. It is very difficult to single down on a small single value or a range which can be used as a diagnostic threshold. So we should always use the clinical context and the other findings like culture possibility for making a diagnosis. In contrast to infants and children, it is recommended not to use CSF serum glucose ratio because it is shown to be inferior to even CSF glucose value. Because there are multiple reasons. Neonates are usually acutely ill, they have stress response, they have ongoing glucose infusions, so this ratio may not be reliable. So what happens with delayed processing? Again, this was studied by Professor Riton, published in Archives of Diseases in 2010. So what it showed is it significantly alters the result. So this is problem in many government hospitals, even in private sector, where we do the tests, but we don't have the lab available 24/7. Especially if we do after the working hours, there may be significant delay in processing. So what happens after delay? So there will be a faster decline of CSF parameters when the initial WBC count and protein was higher. And WBC count declines faster compared to the glucose. In this study, actually, what they saw is among babies who were labeled as pleocytic, more than 30 per millimeter cube, 53% of those babies, almost half of those babies, when the same sample was repeated after 2 hours, this pleocytosis was no more there. So we are likely to misdiagnose in many cases. So you can see if the CSF parameter is analyzed within 30 minutes, the mean WBC count was 36. At 2 hours, it becomes 28, then it becomes 24. So there is a dramatic decline, and we can miss the diagnosis of meningitis if you are basing it based on clear. Similarly, with the neutrophil count, glucose, there is no dramatic fall, but there is a fall in the symptom. The next challenge is traumatic taps. Frequently, we find the taps are grossly traumatic. Sometimes they are not grossly traumatic, but when the analysis is done, we see that there are many RBC. It is defined as more than 1,000 RBC per millimeter cube in the CSF sample. If such a thing is there, it is a traumatic. So as discussed previously, we should first send the CSF culture, and if possible, we can send the other test. CSF glucose has many problems in traumatic taps, so it is not preferred to be used. And there is many people use the corrected CSF count. We will just discuss about this. So it is actually problematic. It is not the most ideal method of using. So there is a data from 2 large studies, the same Greenberg which I was telling, and Lyon. Both have used this corrected WBC count. So what they found is corrected WBC count has lower sensitivity. There may be higher specificity. So lower sensitivity is a problem when we are using these rapid diagnostic tests. We don't want lower sensitivity. We want them to be highly sensitive. So here it becomes a problem in using the corrected WBC count. Sorry for the poor quality image, but what we can see is as we note the sensitivity. Uncorrected WBC count has the highest sensitivity, but it's very, very poor specificity. When we start correcting, you can use any formula, the sensitivity decreases dramatically. This is from 88%, it is dropping to 66. So this is very poor sensitivity, which we can use in testing. Similarly, when it comes to CSF protein, again the same thing. If you correct CSF protein for WBC, for the RBC count, again the sensitivity will go down. But so specificity may increase a bit. You can see here sensitivity decreases from 74 to 61. Specificity increases from 36 to 56. But whatever it is, the diagnostic accuracy is not that good. So it is so ideally what we should do then if we can't correct, there are challenges with using the uncorrected things. So always send CSF culture as the first sample. Continue antibiotics pending CSF culture and report, and repeat a CSF after 24 to 48 hours. Then see the reports. If all the reports are suggestive of absence of meningitis, then you can treat it as a suspicious of meningitis. So this is the most practical approach you can use. And antibiotic pre-exposure, we all know it decreases the culture positivity rate, and especially in these cases, it is more valuable to send CSF PCR. And we are not very sure what happens to the cytochemistry, although we have data in older children. In neonatal age group, we are not sure what happens to the CSF cytochemistry on antibiotic exposure. So to summarize, we have many challenges with the traditional method. Prior antibiotic administration, which is a common practice, results in negative cultures. Delayed processing can result in false negative testing, and the lack of accurate data and diagnostic accuracy makes the interpretation challenging. So do we have any solution for this? So there is no single answer, but many people have started using nucleic acid amplification test, or I would say polymerase chain reaction. So what studies have found that is, so this I'm just representative data from 3 studies, Hoven, NGM, Wang. So they studied 37, 324, and 56 units. So among those units, all were evaluated for the CSF and affected of rate of infection. You can just see the comparison of CSF culture rates and CSF PCR rates. So in Hoven study, only 2 of 37 turned out to be CSF culture positive. But when they use PCR, the positivity rate increased to 11 dramatically, almost 5 times. The same happened in the next study. 4 came culture positive of 324 and 20 came positive with the PCR. And you see the same thing again, almost 5 times increase in incidence. 5 were CSF culture positive and 25 were CSF PCR positive. So all this data is from the neonates, and they have used these probes. One of them has used the broad-based 16S RNA, but others have used specific probes, which are available in our country. I will just show you in the upcoming slide for the diagnosis. So should we use that? Definitely, if it is available and the patient can afford, it should be included for the evaluation of CSF. But there are some problems which we should know. It increases the cost. There is a limited panel. It doesn't cover the common neonatal bacteria like Enterococcus or like Acinetobacter, which is the commonest cause of EOS and OS in India, Klebsiella, and it doesn't give sensitivity. Although it isolates the organism, it cannot give sensitivity. And we have to be very cautious with the sampling technique because even the smallest contaminant can get picked up as a pathogen. So we have to be much more sterile and robust in collecting the samples. But all said and done, it can dramatically improve the diagnostic yield. And also studies have shown that when we use PCR, we are unlikely not to treat a actual meningitis cases. So it is always prudent to include. So we have one panel available. I think many labs must be offering bioscience, and as I said, it includes bacteria like E. coli, GPS, and Listeria, but Streptococcus, Haemophilus are not really common in newborn. Some viruses are also there. It costs around 20,000. The problem is these are not specific to the newborn. These are mainly diagnosed, designed for the children and adults and elderly. So we can use, they will increase the yield, but again, they are not foolproof because we are missing upon the common organism. And the turnaround time is very rapid, around 1 hour. If you have it in house, if you have to send to a lab far away, again, it will take a lot of time and it is quite costly. And some Singapore-based company has improvised this further, and you can keep this small equipment in your side lab, in your NICU, and start using it. It costs around 20 to 25 lakhs. And again, the panel is slightly elaborate with the Mycoplasma pneumonia and Streptococcus pyogenes included, but again, it is not specific to the neonatal case. So we do have options, but they need to be more refined. And maybe in the future, we get more studies focusing on neonatal bacteria. So some people have also started using CSF procalcitonin, just like we use the CSF WBC glucose and protein. This is data from some 4 studies. But here, what I want to highlight is it is not associated with any increase in diagnostic accuracy. So it is as good or bad as in CSF rapid diagnostic test. So I will stop the diagnosis section. Now I will briefly tell a few slides about the management. And empirical therapy, at the level when we start empiric therapy, we never know whether the baby is having sepsis or meningitis. So naturally, the choice of antibiotics will be as per the bacteriological profile and your unit policy. So whenever we are treating any baby, we will start with antibiotics or policy. The early onset sepsis group, we can start with a penicillin, glycoside, or we can add penicillin to an extended spectrum cephalosporin, which covers most of the bacteria causing sepsis and meningitis. And LYS, it should be based on the unit antibiogram. If initial reports are suggestive of meningitis, like the CSF cell count is very high, 50, 60, or 100, more than 100, we can change the dose to anti-meningitic dose. For example, for ampicillin, meropenem, we need to change the dose. For some antibiotics, we don't have to change the dose, but whenever it is required, we can change it. And definitive therapy, it is based on CSF culture, and we have to give a single lower grade and narrower spectrum antibiotic, which is less toxic. That is just like neonatal sepsis. We don't need dual antibiotics, but I will discuss that in the subsequent slide. And the duration is 14 to 21 days, 14 for gram positive, 21 for gram negative. One RCT by Mathur sir et al. Compared 10 versus 14 days, and they did not find any significant difference in the outcomes. There is a shorter hospital stay. And organism specific management, these are all expert based consensus. You are not evidence-based guidelines. These are taken from the up to date. GBS, we give ampicillin for 14 days, gram negative. If it is susceptible to ampicillin, we can give it. And some people add aminoglycosides like amikacin or gentamicin till the CSF clears, which usually takes 2 to 3 days. And non-carbapenemate producing MDR, we can use meropenem. Carbapenemate is quite a big challenge because we don't really have drugs which cross the blood-brain barrier. Listeria monocytogenes, again, it is similar to the gram-negative bacilli. We can give aminoglycoside with ampicillin till the case of clear, then change to ampicillin monocyte. Staphylococcus aureus, usually it requires for 14 days. Should we repeat a lumbar puncture? This is one common question we face. There is no evidence to support this, but some people do repeat. If it is a culture negative meningitis, it is not required. If it is culture positive, especially CSF culture is positive, one can consider. But you think the baby is not responding. Suppose the baby is mounting fever, there is maybe not clinically well, having neurological symptoms despite initiation of therapy, or maybe you should repeat a lumbar puncture. And when we should repeat 24 to 48 hours after antibiotic initiation. It is also safety if the baby is really septic and you do it very early in the course of the infection, the CSL. Sometimes the report may be negative, and when you repeat the second time, it may become positive. That is also one thought process. So any CSF which is positive for GBS, diphtheria, gram-negative bacilli, or with a complicated course, you may consider doing a repeat lumbar puncture. And when we are managing meningitis, we should always monitor for complications. It can be ventriculitis, it can be obstructive, or it can be infective, and there can be subdural empyema. There can be small vessel thrombi, like we see in the adults with meningitis. There can be intracranial abscesses and parameningeal abscesses. So we frequently monitor the head circumference, whether physically the baby is responding or not, seizures, hyponatremia. So if there is rapidly increasing head size, we suspect hydrocephalus, and neurosonogram with a diagnostic reticular type is required. If there is persistent fever in a child diagnosed with meningitis, subdural empyema is a likely diagnosis. We need an imaging, contrast enhanced imaging. And if there are multiple seizures in a baby diagnosed with meningitis, it is either because of stroke, microvasculitis, or macrothrombi, or an abscess. So we need to get an MRI. And hyponatremia can be because of SA. So, and there are many other therapies which are not of proven benefit in the neonatal age group, like intraventricular antibiotics, dexamethasone, IVIG, GCSF, GMCSF, oral albuterol. So all these should not be used in management of meningitis in the neonatal. Thank you. Open for the question.
So thank you so much, Dr. Rajendra sir. I think the participants can put their questions in question and answer box. And I think we can take all the questions after the second session as well. Sir?
Okay, I will stop sharing.
Yeah.
Maybe I'll make some quick few comments.
Yes, sir, please.
Yeah, Dr. Rajendra Prasad, he has very nicely and clearly enunciated the principles and diagnosis and management of neonatal meningitis. There are a few practical issues which need to be highlighted. And as he has very clearly said that all babies with sepsis or with, say, the systemic inflammatory response syndrome, clear clinical features, they all should have a lumbar puncture before the starting of antibiotics. And that message should be very clear, because the lumbar puncture should not be delayed for any reason. A bigger challenge is culture negative pleocytosis of CSF in a sick child. That is the real bulk of meningitis that people treat. The culture positivity, unfortunately, for various reasons, one of which could be delayed lumbar puncture. The culture positivity is something like 20 to 25% of all this pleocytosis in sick children. So that is the challenge that we face. So there are two important sort of implications of this. Number one, why are we missing the isolation of organism, which means we do require, say, more advanced molecular and genetic tests to make the diagnosis. And it is surprising that from our country we don't report group B streptococcus. So GBS is not the issue. If you see the Western data, they have GBS as the main bug in sepsis as well as meningitis. But in our country, in our context, GBS is hardly an issue. We don't see listeria, but the reason could be different. The reason for having less GBS could be different. For having less of listeria could be different. Maybe we require an
Sir, please unmute, sir.
yeah. So in view of this, the short term or the duration of antibiotic, there are for management also there are two or three challenges. And number one is the initial antibiotic, and that initial antibiotic would definitely depend upon the data, the unit data, which, because most of the meningitis would be rather culture negative, we would just have pleocytosis to treat with. So we can only go by the prevalence of the bugs that we have in our situation, and that can decide the initial antibiotic. And the second issue of duration of antibiotic. Now, there is no guideline available for a pleocytosis in a sick child with culture negative meningitis. So, in that case, it's very important to see the resolution of clinical symptoms, the imaging data, and the repeat CSF findings, and based on that, a shorter duration of management of neonatal meningitis is definitely possible. Now, so far as the supportive management is concerned, there is very limited data on the use of supportive agents, and that's why we often conclude that these have no role. But it may probably be possible that we are not having sufficient data and we don't know much about it. So, particularly in places and in units where the mortality with the neonatal meningitis is high because of any reason, like maybe they are receiving babies in late stages. See, there are three situations in which the units in our country function. One is units which largely cater to inborn newborns, and the other is the private sector and the district hospitals where majority of the newborns are outborns and they have late onset sepsis. So in these situations, maybe the epidemiology and the causative bug may be different. So probably these are some of the issues that we need to further continue to work on and generate data. For example, in the study, in our study where we used dexamethasone, it's not yet established as to whether we should use it or not, but definitely it reduced the CSF cytokines, earlier resolution, and improved survival. So those have been noticed in shorter studies, but the data is not conclusive. So I think with these remarks, I really thank Dr. Rajan Prasad for a very clear and concise message and information on neonatal meningitis. Thank you. I think we go to the next talk. So thank you. Over
Thank
to
you.
you, Dr. Kirti.
Thank you, sir, for your valuable comments. For the next session, we have Dr. Manisha Jana, who is a professor in the Department of Radio Diagnosis and Intervention Radiology from AIMS, New Delhi. Ma'am will be talking on the neuroimaging in neonatal meningitis. Over to you, ma'am.
Thank you, Dr. Kirti. Thank you, sir. So I'll be talking about imaging in neonatal meningitis. So as we know, as has already been discussed in the last talk, when to do lumbar puncture, when to have the baby for imaging, those things that is quite clear when to do. So the role of imaging in neonatal meningitis, it should be done before a lumbar puncture if there is any focal neurodeficit or any statal epilepticus or poor Glasgow score. If there is suggestion of raised intracranial pressure, or if we are suspecting complications of meningitis, to diagnose that and for monitoring of them, imaging is crucial. And of course, in the neonatal units, ultrasound is the modality to go for because it is available bedside and you can repeat it easily whenever required. But whenever the baby is fit enough to be transferred to the MR suite, MR is preferred over CT. Now, as we are talking, cranial ultrasound is the primary evaluation, and it should be done at the baseline at the presentation of the symptoms. And okay. And whenever there is a need or there is a symptomatic worsening, we can repeat it. It has got no ionizing radiation, although it is user dependent and a subjective modality. But with a little bit of training, it does not take a very long training. So even the neonatologist can perform it bedside with reasonable accuracy. The limitation is that how is the visibility on cranial ultrasound? It totally depends on the size of the fontanelle. So if in cases of suppose microcephaly, there is a small acoustic window, the visualization might not be that good. And posterior fossa evaluation is most of the time suboptimal. How do we do it? Usually we use a sector probe, which has got a very small footprint and a large area of coverage. So it fits the fontanelle well because it has got a small area that it to be put in, whereas the imaging area, it is bigger. And in cases of the subarachnoid space evaluation or superficial structure evaluation, better resolution will be seen on a linear transducer. So this is a curvilinear or sector probe, how it looks like. So this is the footprint, the area where the probe touches the body, and see it expands. It expands as it goes in the depth. And even at the depth also, the resolution remains equally good. Wherever this is the linear transducer, it gives superior anatomic detail at the superficial part of the brain. So therefore, we can see the superior sagittal sinus in this coronal image on the linear transducer. Also, we can see the subarachnoid space with traversing vessels very well. You can see the pial echogenicity. Normal pial lining is thin, smooth, echogenic. But as we go in the depth, the resolution falls. So this curvilinear or sector probe is essential with an adjunct use of this linear transducer to see for any extraaxial fluid collection and the status of the veins, venous sinuses, and also vascularity around the meninges. So let's see what are the imaging findings on ultrasound. The imaging findings can be subgrouped as meningeal or extraaxial findings, intraventricular findings, or parenchymal findings. In meningeal or extraaxial findings, on ultrasound, the most common or sensitive finding is widening of the brain sulci or the meningeal covering that covers on the gyri, it becomes thick and echogenic. Then the cortical vessels, they become prominent. We can see that there may be extraaxial fluid collections, subdural or subarachnoid fluid collection. Subdural empyema can also be seen if the proper technique is adopted. Interventricular findings include, there can be intraventricular debris or septations, and eventually there may be a trapped ventricle, and irregular and echogenic ventricular wall is another early imaging finding. Parenchymal findings are variable in ultrasound detection, and the sensitivity may vary. There may be abnormal parenchymal echogenicity as in cases of infarct or cerebral edema. So let's see how do they look like. So if we just go back and see how the normal appearance looks like. So the sulcal, the gyri, they are covered with this very small, very thin, smooth, echogenic pile lining. Whenever there is a single lining, it measures around 1.3 millimeter, and whenever there is like double folding of two meninges, like here, it should not be more than 2 millimeter. If we see in this transcranial ultrasound, we can see that this echogenic sulcal echogenicity is much increased. It is much more than 2 millimeters. So this sulcal echogenic widening of the brain sulci is one sensitive finding of meningitis. Also, we can see that there is ventriculomegaly in this side. If we do the same thing on a linear transducer, high resolution transducer, we can see the difference in appearance. However, we can see that this subarachnoid space, normally it should be completely echo-free. It should be completely black like this. However, here we can see there are multiple echogenic areas or debris within the subarachnoid space, and multiple vessels can also be encountered. These are all abnormal findings that we can see in meningitis. In addition, this side also had ventriculomegaly, and here this asymmetry dilatation of the left-sided ventricular frontal horn that we can see over here. Now, the echogenic content in the subarachnoid space may vary in its echogenicity. Like in this child, we can see, so this is the pile lining. This is the pile lining. This is the scalp. And this triangular hypoechoic area is the venous sinus. And all this echogenicity that we can see from here till here is the subarachnoid space, which is filled with echogenic debris. This is very highly suggestive of meningitis. Sometimes in the superficial linear transducer, we can very well delineate the extraaxial fluid collections. Like here, this is a subdural exudate and this is a subarachnoid space exudate. So this is the dura which has been displaced by the subdural collection. And here we can see this is the subarachnoid space collection. Now, how to differentiate between subdural exudate and subarachnoid space collection? If we put on a color Doppler, we will see vessels in the subarachnoid space, which normally travels through the subarachnoid space, whereas it won't be seen within the subdural exudate. Now, subdural exudates, whether it is just simple effusion or it is subdural empyema, that is difficult to comment. MR, of course, serves better in this regard. Amongst the intraventricular findings, echogenic ependymal lining is one of them. Although they are not seen in many of them, but whenever seen, it is quite suspicious of meningitis. Like here, we can see normally ventricular lining is never this continuously echogenic. So this echogenic ependymal lining is one finding of meningitis. Ventriculomegaly, although non-specific, but in a given setting, it is also an important finding. And ventricular debris, usually they are seen in the dependent location. So when we are doing ultrasound in a neonate who is supine, the debris are supposed to be found in the occipital and the temporal horn region, more in the occipital horn region. So the transcranial from the anterior fontanelle ultrasound probably is not going to show you the debris in this location. Rather, transmastoid approach will be better to show the debris within the uh, occipital horns of the ventricles. Sometimes as a sequel of ventriculitis, what we see is adhesion formation within the ventricle, and that results in one part of the ventricle being sequestered, being separated out, called trapped ventricle. As we can see here, there is adhesion formation within the ventricle. So a part of the ventricle will enlarge. Amongst the parenchymal changes, they have variable, they're found in variable percentage. However, this was the complication of meningitis in a neonate, where we can see this is the middle cerebral artery territory, which is the Sylvian fissure on the left side, which is echogenic. If we compare with the right side, this is very much echogenic, and this is normal hypoechoic area. And it is conforming to the vascular territory of the left MCA, as well as the PCA territory. So this typical appearance, this is suggestive of an infarct. In addition, we can also see the basal ganglia. The basal ganglia is appearing very echogenic, which is unlike that of a normal appearance. Normally, the basal ganglia should also show this kind of echogenicity. So there can be an edema of the deep brain nuclei, as well as infarct in the left MCA and PCA territory. Brain abscess as a complication of meningitis, unusually detected on ultrasound because of the inherent limitation that we may not be able to properly scan the entire brain in all children. But however, when they are seen, they are seen like this focal hypoechoic areas. In this child, we could see that these abscesses, they were seen as small hypointense on T1 and diffusion restricting lesion over here with some peripheral rim enhancement. These were brain abscesses. Now, talking about complications with trapped ventricle or secondary to ventricular adhesion, that we have discussed. Now, sometimes cerebral venous sinus thrombosis can also be detected while doing a cranial ultrasound, because on this coronal high resolution transducer, if we saw that we can see the superior sagittal sinus very well with very good resolution. So if we just put a color box inside and see that there is no flow inside, it is a very good tool to both detect as well as monitor, because for MR, repeated MR, it is not without the hazards of repeated sedations, and scanner time is also not that much easily available. So this can be used as a monitoring tool in complications. Now, whenever we are doing CT, CCT is preferred in the setting of a suspected meningitis over NCCT, because the predominant finding that we are looking for is leptomeningeal enhancement. But to say that if we are seeing no meningeal enhancement, that doesn't mean that we are excluding meningitis. No. It has got variable sensitivity. It is not 100% foolproof that meningeal enhancement will always be present in all meningitis kids. And the main drawback that we know, it comes with its radiation burden, as well as the need to shift the child out of the NICU. And also CT is not that good in detecting white matter changes, which MR can show in a much better way. However, what are the imaging features? The imaging features can range from meningeal enhancement. As we can see, there is excessive meningeal enhancement. For this, we need to keep a check on the timing after contrast injection. If we take very early scan after contrast injection, there may be a spurious appearance of meningitis. However, here in this side, we can see there is ventricular enhancement as well as a brain abscess that has already formed. In this, sometimes the ependymal enhancement can be focal or minimal as well. Like in this side, there was ependymal enhancement in a focal discontinuous way along with abscess. Now, MR, we know it is superior to ultrasound and CT, but only if the neonate can be shifted outside the NICU. And contrast is preferred. If we are not able to give contrast, at least diffusion weighted imaging must be performed. Although diffusion is now a part of all the routine brain scans. The imaging findings include meningeal enhancement, ependymal lining, ventricular enhancement, intraparenchymal findings, and intraparenchymal abscesses, infarcts, or extraaxial collections. Now, sensitivity in detection of meningitis is variable, but quite high to the tune of 80%. Specificity is very high. And the negative predictive value, as like in CT also, it is variable. And the most sensitive imaging finding for meningitis is leptomeningeal enhancement. Most specific findings are ventriculitis, abscess, and infarct. About the timing of MR, when should we do the MR? It says that it should be done better within the first 10 days or better within the first 1 week, because the sensitivity decreases after that, whereas the specificity remains almost the same. Now, what are the imaging findings? Suppose we are not able to give contrast. In such a situation, these are the basic sequences that we perform: T1, T2, flare, diffusion weighted image, and the ADC map. So on T2 weighted axial image, we could see that, so this is non-myelinated brain matter, T2 hyperintense white matter in a neonate. And we can see that the ventricles are dilated, and the content within the ventricle, which should be suppressed in flare, like because it suppresses the fluid signal. So the normal CSF should be suppressed and should appear black like this. However, whenever there is debris, like in this occipital horns of both the ventricles, they did not get suppressed or completely black. So that means it is full of debris. In these diffusion weighted images, they will appear hyperintense, whereas in ADC map, they will appear as dark, suggesting that they are like collection of thick debris or pus. If contrast is given, we can see that there is abnormal ependymal enhancement along the ventricular lining, quite thick enhancement. We can see the thick enhancement along even the aqueduct, and abnormal meningeal enhancement as well. All these features are suggestive of meningitis. In some a little more advanced cases where we can see the various complications, like in this case, there is an adhesion formation already. We can see the debris within the ventricle, which is showing diffusion restriction. And there is persistent ventricular wall enhancement, and that trapped ventricle is also showing enhancement. If left not properly treated, this is what may happen. The surrounding brain parenchyma under pressure and under this ongoing inflammation might undergo this kind of might undergo edema and areas of liquefaction like this. So here is another complication of this ventriculitis, whereas this entire hemisphere has shown this kind of edema, as well as multiple other pockets of like ventricular adhesions. The similar child, after a while later, when the CT was done, see the gliosis has already set in, and there is volume loss of the entire hemisphere. Now, can we predict patterns in various organisms in neonatal meningitis? Well, there are a few specific patterns described in a few organisms in bacterial meningitis, like group B streptococci. They in these parenchymal findings like small areas of infarcts, multiple infarcts, or ischemic complications are commoner than ventriculitis or extraaxial fluid collections or empyema. Whereas E. coli, they presents more commonly with extraaxial fluid collection or empyema, subdural empyema or ventriculitis. Rather, parenchymal findings are much less common. Meningococcal infection can present with extraaxial fluid collection or empyema and focal areas of infarct leading to cortical laminar necrosis. Serratia is also, although not that common an organism, but they can present with quite bad looking, severe, like multiple large intracranial abscesses with characteristic appearances. So I'll just show the example from this article that I quoted here. So this is how a streptococcal meningitis would look like: multiple intraparenchymal deep areas of infarct, whereas if we see, there is not much ventricular dilatation. This is E. coli, where the ventricular dilatation and ventricular debris, extraaxial fluid collection is the predominant finding. This is meningococcal infection, where extraaxial fluid collection we can see, and cortical laminar necrosis of the right occipital lobe. This is serratia, where multiple areas of intraparenchymal lesions which are showing this typical striated kind of appearance. Enterovirus infections, they present with this white matter involvement more predominantly in the periventricular region. And tuberculosis, the picture we are familiar with is this typical thick basal exudates along with tuberculomas or and adjacent to it or within the parenchyma. So to end the imaging findings, ultrasound remains the first imaging modality, and for monitoring, for bedside monitoring, ultrasound is a crucial tool. We also need to see the resistive index on Doppler because that might give us a clue when the ventricle is under tension and whether you need to tap. And contrast MR is always preferred whenever possible. If we are not giving contrast in MR, diffusion weighted imaging is useful because that characterizes whether there is parenchymal infarct or the ventricular collection that we have, they are pus or debris or not. And role of imaging is crucial in cases of both diagnosis as well as detection of complications and monitoring. Thank you all for your patient hearing.
Thank you, ma'am. Thank you so much. The house is open now for further discussion. Atul sir, you want to say something?
Thank you, Dr. Manisha, for elaborating the different imaging modalities and including the timing, which is very important. A few practical issues. While ultrasonography, MRI remains to be the best modality, but for neonate, the issue of shifting the baby to the MRI unit and sedating the baby, so those issues become very important, and we are really missing very important information of MRI changes in neonatal meningitis and its utility in making diagnosis.
Right.
The timing of imaging in neonatal meningitis is quite important if we particularly see it in light of the neuropathology, because this meningitis, it starts as a choroid plexitis, and then there is subsequently ventriculitis, and then arachnoiditis, and then vasculitis, infarction, encephalopathy, and edema. And then this happens in the first week, and in the second week we have the sequelae like the hydrocephalus, porencephaly, loss of neurons, the organizational problems, cortical organizational defects. So those things come as sequelae in the second half. In the first half, when diagnosis of meningitis is very important, ultrasound being a bedside modality is really very useful. And I wish that we are able to utilize more MRI for management of neonatal meningitis. And we have more dedicated radiologists who are sort of dedicated to imaging of neonates. So with that, thanks, Dr. Manisha, and over to you, Dr. Kirti.
Yeah, thank you so much, sir, for your comments. I think most of the questions on Q&A has been answered by Sir Dr. Rajendra sir. There are a few questions that we would like to take. Is it fine, Dr. Rajendra sir? We can discuss. Yeah. So one is like, can we label meningitis only based on high protein and low CSF sugar?
So it's a very tricky situation. If you consider giving benefit of doubt to the baby, better to treat that high protein and low CSF sugar. But how high, how low, that is one more question which we don't have the correct answer for.
Yes, so it is always a dilemma.
Yeah.
This, right. So, but it is always better that you treat,
Yeah.
and at least for 14 days you treat, and then you can. Do you suggest a role of repeat CSF to see whether it has cleared or not?
Again, this is very difficult question to answer because we don't know what is the exact reason why protein was high and CSF was low in the first place. Some people do, and if it is still not fully normalized, extend the antibiotic course for a week or something. But I don't think it will add anything to the diagnosis and management, repeating a CSF in this doubtful cases. I think we should just give the minimum duration required, 10 to 14 days of antibiotics, which will cover both sepsis and meningitis, and complete the treatment.
Yeah. So for culture negative meningitis, can we treat for 10 days? That's another question by Dr. Patel.
Probably 10 to 14 days, because even Mathur's trial has shown that even 10 days is not inferior to 14 days. Maybe 10 to 14 days would be a good option where we have doubt of meningitis.
So I have a question about like the patients who get complicated to ventriculitis, like meningitis and ventriculitis, and we often try to treat them for as long as possible, like more than 4 to 6 weeks of antibiotics that these babies will get.
Yeah.
So, do you suggest like, and still like that you will get that when you do the repeated ventricular taps, the CSF will still show high proteins and low sugar. So there is no end point to that, right? Like how long to give the antibiotics in that case?
So especially in these obstructed cases or when there is ventriculitis, the CSF protein will typically remain high and sugar will remain low for a very long duration. So maybe it is more prudent to decide our antibiotic therapy based on the CSF cultures and the cytology. So protein and sugar typically take longer time whenever there is an underlying obstruction. Better not to rely on those two parameters. And 4 to 6 weeks of antibiotics is the standard therapy. And some studies have compared 4 weeks, intravenous versus intravenous plus intraventricular. And there is no adequate data, but preliminary results suggest that if we are giving sensitive intravenous antibiotic, that is enough. No need to do repeated ventricular taps, because in the process of doing the taps, we may be damaging the parenchyma also.
Yeah, I think that's true. And there's one question for Dr. Manisha, ma'am, that what are the indications of MRI in the case of neonatal meningitis?
So per se, if it is always preferred if we can do it, but whenever there is worsening or we can there is worsening and we are suspecting any complications, then we should get it. And moreover, even in severe cases for prognostication also. So,
yes. So if it's possible, you go ahead with MRI.
Yeah, if it's possible.
Also, one comment that studies have shown there is no need to do correction for traumatic CSF, then how to interpret cytology in such cases? I think question to Dr. Rajendra.
Yeah, it's not that there is no need to do correction. Even if you do correction, it will not help with the diagnostic accuracy. That is what the studies say. So ideally, what we should do is we should not give any value to the corrected, uncorrected WBC, whatever, from a traumatic tap. Traumatic tap should be used only for culture and gram stain, and we should repeat a tap again after 24 to 48 hours, preferably by a different person, more skilled person, and try to get a traumatic tap.
Yes, so it is no use. The traumatic tap for interpretation of cytology is of no use.
Yes.
Yeah. So, and what about protein and glucose?
Glucose, again, protein also, but the answer is same. There are corrections proposed, but it decreases the sensitivity. So better not to interpret the protein also. Glucose, definitely we should not do.
Yes.
So for the practical reason, it's only gram stain, culture, PCR are the only three tests which can be relied upon when we have a traumatic test.
Yes. Yes. So I think we are running also out of time also. So thank you. On behalf of NNF, I would like to express my gratitude towards the eminent speakers that we had today, and we had a lot of good discussion. And a special thank to Mathur sir for his valuable comments as well. So I think we can stop our program. The program. Thank you. Thank you so much.
Thank you. Thank you, Madhu sir.
Thank you.
Thank you, sir.